Muted.
All right, so MLTC. So, you know, is ICAN really handles a lot of these MLTC cases and also the new FIDA program, and even mainstream consumers who need long-term care. So obviously there's some overlap between what CHA does and what ICAN does. And so I'm going to just talk a little bit about ICAN, and then we'll give an overview of MLTC and go into some more depth about a bunch of MLTC related issues that you might encounter, and then a little primer on FIDA for those of you who are downstate. FIDA is not statewide, but I think it's something that for those of us who are downstate, there's going to be a lot of attention on over the next year or longer. So ICAN stands for Independent Consumer Advocacy Network. It's built off of a similar model to CHA. It's a hub and spokes network. We've got 14 agencies around the state. We're statewide. We've got a toll-free helpline. People can meet in person with ICAN counselors all over the state. We educate and advocate for people who want or receive Medicaid long-term care through managed care plans. That's the short definition of who our clients could be. We're funded by a grant from the New York State Department of Health, and our services are free, confidential, and we are independent from all health insurance companies. So a lot of similarities with CHA there. This is just a map showing our network and which agencies we work with. So obviously some familiar faces there. And this is our helpline number. We're open Monday through Friday, 8 a.m. to 8 p.m. And you reach a live health counselor. We don't have volunteers answering the phone, and ICAN. We probably will at some point in the future, but right now you're 90% of the time you're going to reach a staff full-time health counselor, and they're going to be able to start answering your questions right away, and go straight into opening a case if need be. We have counselors who speak Spanish, Russian, and Chinese. And when you call that hotline, someone from any of these other 5 organizations might also answer the phone. We have phones at Legal Aid Society, MRC, NILAG, etc. And so we really appreciate the help of all of our specialists who have, helped us handle that the call volume that you inevitably get when the State Department of Health puts your phone number on 100,000 notices. So we do a lot of the same kind of casework that CHA does. It could be from a 10-minute advice call all the way through to representing someone in a hearing. And we've had actually since in our first year, the number of cases is actually more like 9,000. So these numbers are a little bit old. And we do a lot of community education and outreach as well. We have a very spiffy new website, which I encourage you to check out. Where it's a lot of it is really intended for the layperson, for consumers or caregivers. So you might find the information to be a little bit too oversimplified for an audience of advocates, but we are trying to get a section of that site that does have more of the nitty-gritty materials that advocates would want to look for reference, plan lists, guidance, how-tos, stuff like that. So you can click on the Learn More button to get to the what I like to think of as the nerd room of the website. We also have materials available in 9 different languages, which is pretty amazing. And like CHA, we try to monitor for Sentinel issues and report those to the state. So let's get into the nitty-gritty here of MLTC. And I'm just going to check, I guess if people have questions, if you could just raise your hand. I mean, I'm going to try to, I guess, try to hold questions to the end just because it's going to be hard for me to pay attention to the webinar widget as we're going, but I'll try to keep an eye out for it. And if you raise your hand, I'll try to get to you. Patricia, you're not actually, you don't have a question right now. That was, oh no, you do. Okay. Hey, Patricia.
No question. No question.
Oh, no question? Okay.
Yes, I thought I was putting my hand back down.
Okay, your hand is down. All right. So the threshold question, which probably a lot of you already know. What is Medicaid loan? What is this long-term care thing? The state loves that term long-term care, which means absolutely nothing to any humans who are not actually involved in this work. There's not necessarily anything long-term about it, but what they're talking about is basically care that isn't medical care. It's the assistance of another person to help you with your activities of daily living. So it's not treating your medical condition. It's just helping you function if you have functional impairments. And this could apply to a lot of the very elderly. It can apply to younger people with disabilities. It can apply to kids. So the most common service that we're talking about is personal care services. That's a Medicaid state plan service that was historically covered under fee-for-service Medicaid and is now part of managed care. It also includes the services you get from a CHA, a certified home health agency, like a home health aide, physical therapy in the home, occupational therapy in the home, a visiting nurse. It includes private duty nursing for those individuals who need a skilled nurse every day. Adult day health care, which is another word for medical model adult day care. So this would be a program where, for example, for an older adult with dementia, they could get picked up and brought to a center during the day where there would be activities and personal care assistance there if they need help getting to the bathroom or meals, and possibly some medical care at that center as well. And the consumer-directed personal assistance program, where a consumer could choose their own aides and be responsible for recruiting and training and supervising their aides. That is also a form of long-term care. There's also institutional long-term care. So if somebody, for whatever reason, was not appropriate for receiving care in their own home, their own community, Medicaid obviously also covers permanent placement in a nursing home. And as you all know, Medicare doesn't pay for long-term care services. I just got a funny email from a client saying, I found a great new health insurance plan for myself. It's called Medicare Part G. It's for gun. So you can shoot your congressman, and then they'll send you to jail where you'll get free medical care for the rest of your life. Because Medicare doesn't pay for nursing homes, so that was their proposed response. So at least my disturbed client has a sense of humor, and because Medicare doesn't pay for long-term care, this is why people are looking at Medicaid. This is why you have a lot of people who are maybe not traditionally, when they were in their working days, they may never have thought about applying for Medicaid. They have too much income, they have savings, etc. But Medicaid is one of the only types of health insurance that pays for long-term care. And one of the big changes a couple years ago was that now there's a law that almost all dual eligibles in New York State, if they want long-term care services, they have to enroll in a managed long-term care plan. Medicaid, straight Medicaid, fee-for-service Medicaid generally does not pay for long-term care anymore. And that's true for home care and nursing home. If you need any long-term care services, you've got to be in some form of managed care in New York State. So there's different kinds of MLTC, and it's very confusing because the state will use the term MLTC to encompass all of these types of MLTC plans, but they also use it to refer to one specific type of MLTC, which is what we'll be calling partially capitated or Medicaid MLTC. MLTC is a program generally for dual eligible adults who need more than 120 days of long-term care. So if you don't need it on a long-term basis, if you just, let's say you're a dual eligible and you are discharged from the hospital and you're getting CHA services, Medicare does pay for CHA. It pays for a short-term CHA episode. It may be a few weeks, maybe a month. In theory, it could be longer than that. But if you need fewer than 120 days of that CHA service, you're not required to enroll in an MLTC, even though you are dual eligible and even though you are getting that home care service. It's only once it goes past 120 days. Now, for someone who's looking for personal care, they don't just have a short-term episode because they got out of the hospital. They're really like, okay, my mom can't function at home anymore by herself. We really need someone to help her out. I can't keep doing it. I have a job. You know, that you're really looking at personal care services, not just a short-term CHA episode. And for that situation, you pretty much can assume that it's going to be more than 120 days. Right? Nobody can go to CASA and apply for personal care services and say, well, I only need it for 90 days, so I don't need to go into MLTC. That doesn't work. They assume that if you need personal care, you need it long term. And that's true for a lot of the other services. I think CHA is the only one where the 120 days really means anything. So an MLTC plan is just a type of HMO. It's a managed care organization under state law. It's a private health insurance company that gets paid a monthly premium by the state, capitation, and that premium is the same for every member in a given plan. It's the same per member per month, and that plan becomes responsible for providing any medically necessary services to their members within their benefit package. Now, the benefit package of an MLTC is different than for a regular Medicaid managed care plan. It's more limited. That's why it's called a partial capitation plan. And we'll see in a second what that includes. As of today, MLTC is mandatory statewide for dual eligibles age 21 or older who need more than 120 days of long-term care. Okay, so it was getting phased in gradually, and we're now completely phased in. So here's what you get. By the way, let me just give a shout out to Empire Justice Center. The entire MLTC section of this was made by the Empire Justice Center, also a partner of the CHA program. So thank you very much, Amy Lowenstein and the rest of EJC, for letting me borrow your slides. So what's in the benefit package? Mostly for a partial cap MLTC, which is what the majority of people in New York State who have home care are in, it's just about home care. It's about your personal care, consumer-directed, CHA services, private duty nursing. That's like 90% of what you get from an MLTC plan. So all of your other healthcare needs you're getting from a different source. Most of the time, Medicare. Because again, these are duals. So Medicare is their primary health insurance, and their MLTC is just about the long-term care services. So they don't have to worry about, well, does my MLTC plan cover my doctor? Is my cardiologist in network? Is my hospital in network? Are my drugs on the formulary? For most MLTC plans, that's not an issue because they don't even cover that stuff. It's not part of the benefit package. It includes, all the things we were talking about before: nursing home, adult daycare. There are also a couple of additional services that are thrown in there. Home modifications, interestingly, are in there. That's something that a lot of people don't know about. If you have a client who's in an MLTC plan and they need modifications made to their bathroom, for example, to make it wheelchair accessible, they should ask the plan for that. They would be responsible for covering it. The same thing goes for durable medical equipment that might not be covered by Medicare. Supplies, diapers, Chuck's pads, that would be covered by MLTC. Transportation to doctor's appointments is covered. PERS, the life alert system. Home delivered meals are covered. And then this is something that's sort of the one piece of the MLTC package that looks kind of like medical care. Podiatry, optometry, audiology, and dental are in the benefit package. So if you have a dual eligible client who has a long-standing treatment relationship with a dentist who takes Medicaid, that is something that might be at risk when they go into MLTC, because you need to find out if that dentist takes the MLTC plan. They're losing fee-for-service Medicaid for their dental when they go into MLTC, and now they have to use the MLTC card for that. So this is the definition of for whom MLTC is mandatory. Again, it's statewide. You have to, anyone who needs any of these services would be required to enroll in MLTC unless they're subject to some exemption or exclusion. One very common exclusion would be people with developmental disabilities. I know we were talking earlier about OPWDD and the waiver program, and that is a population that is excluded from enrolling in MLTC. If somebody with developmental disabilities wanted to get their long-term care services through MLTC, they would actually have to disenroll or kind of, disenroll basically from OPWDD in order to get into an MLTC plan. There probably are not very many good reasons to do that. They should probably stay with OPWDD for now. Patricia, you had a question. Individuals who are Medicaid eligible must enroll in a Medicaid managed care for MLTC. Well, it depends on if they have Medicare or not. So if someone has Medicare and Medicaid and they need long-term care services, yes, they have to enroll in MLTC. But if they don't have Medicare, if they just have Medicaid, then they would get all their long-term care services through their mainstream plan. Because almost all of these services are in the benefit package of a mainstream Medicaid plan. Does that make sense? I unmuted you.
I still need a little bit more clarity. So if they have Medicare, they don't need to. If they have Medicare and Medicaid, they don't need to enroll in a managed care plan.
They do need to enroll in an MLTC if they need long-term care services.
Right, but you said something about being in a managed care program, and so I just wanted to make a managed care plan. So I just wanted to make sure, what is it? Is it just for Medicaid individuals? In order for them to have MLTC, they need to be in a managed care plan?
Oh, well, MLTC is a managed care plan.
Okay.
It's a type of managed care plan. So there are different types of private managed care plans that people in New York State can get their Medicaid benefits through.
Okay.
And the kind of plan that you either need to be in or that you may be in depends on a couple of other factors, like whether you have Medicare and whether you need long-term care services. So if let's say you're a Medicaid recipient and you don't have Medicare, most of the time you have to be in a mainstream Medicaid managed care plan, right? There are very few people who are exempt. If you had a spend down, you wouldn't. If you had comprehensive primary health insurance through some other source, you wouldn't. But most people with straight Medicaid, they have to be in a Medicaid managed care plan. If that person happens to need home care or nursing home care, nothing changes. They would just stay in the same plan that they were already required to be in, and that plan would be responsible for providing home care or nursing home care.
I understand.
So that's one key takeaway, that for Medicaid onlys, people without Medicare, their mainstream plan is their MLTC. They don't need to switch to MLTC. There's a very small number of situations where someone without Medicare may want to switch to MLTC. And sometimes they can, but it's not easy, and it's not sort of the default. 99% of the time, if you're a Medicaid only and you need long-term care services, you should be looking to your plan to get those. And if anybody hears about, for example, a plan telling someone, oh, you want home care? Well, we can't give you home care. You need to switch to our MLTC plan to get home care. That's not supposed to happen. You should let us know about that. Okay. Or let Nakia and Alex and Flor know about that. For someone who's a dual eligible, they may or may not need to be in a managed care plan. If you're a dual eligible who doesn't need long-term care, you don't have to be in any kind of managed care. If you're a dual eligible who doesn't need home care, you can have original Medicare for your Medicare benefits, and you can have straight fee-for-service Medicaid for your Medicaid coverage, and you don't have to touch an HMO. But as soon as you are asking the state Medicaid program to cover something like home care or nursing home, at that point they say to the dual eligible, all right, we'll leave your Medicare alone, but you've at least got to join a managed care plan for the Medicaid if you want us to cover long-term care services. And that kind of plan will be an MLTC.
Understood. Great.
Great question, because it's super confusing, and it's about to get more confusing. So there are some people, as I was just alluding to, who are not required to enroll in MLTC, but they may. They can voluntarily enroll. And the main group here is the non-duals, the Medicaid-only folks at the bottom. If you're 18 years and older and you need long-term care services and you're assessed as nursing home eligible, you can opt into MLTC, even though usually such a person would be in straight Medicaid managed care. All right. If you're already in a Medicaid managed care plan and you're trying to switch into MLTC, that's a lot more complicated. So feel free to give me a shout out if you have someone who you think is in that situation and that has a good reason of wanting to move over from mainstream to MLTC, but it's a little tricky. There are some people who can't get into MLTC even if they wanted to. If all you need is housekeeping. So under state law, if you don't need help with personal care tasks, and I think of this as helping you use or take care of your body, right? So that would be, I need a home attendant to help me take a shower, or to help me get dressed, or help me walk in my apartment without falling, or help me to use my walker, help me get ready for bed, remind me to take my medication. That's all personal care services that help you with using your body. But there are other home care tasks that are just about taking care of your environment, like going grocery shopping, doing the laundry, light housekeeping. That stuff is called level 1 as opposed to level 2. And those tasks are capped at 8 hours a week. That's the most, under state law, that's the most hours you can get if you don't need help with your body, you just need help with your home, with your environment. And if that's all you need, you can't be in an MLTC. And if an MLTC plan finds that somebody only needs 8 hours a week, they should disenroll them. They should be moving them back to the old system. So in New York City, you'd be going to the CASA, and you'd be submitting an M11Q form signed by the doctor, just like in the old days. And in other counties, you'd be going to the local DSS, submitting a physician's order form, whatever form is used in that county, and they would be covering housekeeping just like they used to. If you need short-term care, then again, that would be someone who's not eligible to enroll in MLTC. If you're already receiving hospice, if you're certified for hospice, then you can't enroll in MLTC. But if you are a member of MLTC already and then you're certified for hospice, you can stay in your plan. and keep getting home care from your plan while you're also getting care from a hospice. And then another one is people who only need social model adult daycare. There's two kinds of adult daycare. There's adult daycare that you get in a medical facility like a nursing home, and then there's adult daycare that you get in a facility that's not overseen by a doctor, basically. And these look a little bit like senior centers, but they're not. They provide a very special service for people with cognitive impairments. And if that's all you need, it's social adult daycare, and you don't also need more than 8 hours a week of home care, then you're not eligible to enroll in an MLTC just based on that. Now, if you do need home care, you can also get social adult daycare from your MLTC, right? It's a covered service. It's just not a sufficient anchor for you to be able to enroll just based on that one service. So this talks about, for the Medicaid onlys, if you want to switch from a mainstream plan to an MLTC, this talks about the criteria for doing that. I'm not going to go into this, but you can refer back to this if you have clients in that situation. So who's excluded? Who's left that actually can't get into MLTC? Because most of them have been, as with mainstream under Medicaid redesign, most of the exemptions and exclusions have been eliminated. So assisted living program, if you're in a Medicaid assisted living program, which is a very small subset of the places in New York State that call themselves assisted living. There's some of them that are actually Medicaid covered assisted living facilities, and those are called ALPs, ALPs. If you're in one of those, you are currently excluded from MLTC. As far as I know, they're planning to carve those folks in January 1st. I haven't heard a peep about how that's going to happen or what that's going to look like, so stay tuned. The NHTD and TBI waivers. Again, these are people who get a lot of these kinds of long-term care services but have very special needs and have very special services that you can only get through the waiver. Those folks were supposed to be carved in also in 2016, but were given a one-year reprieve because they really weren't ready. The plans were not ready to to accommodate the new services and the providers that they historically hadn't worked with. So they're given it another year for everyone to work out the kinks. OPWDD waiver is also still excluded, and I'm not really sure what the status is on that one. But I think as of today, if you're in the OPWDD waiver, you've got a code on your Medicaid case that will block you from enrolling. So even aside from a question of state policy, I can tell you that just from a computer perspective, the WMS system will not let you enroll in an MLTC if you've got that OPWDD code on your case. Susan, you got a question? Hi, Susan. I unmuted you if you wanted to ask a question.
Okay. Yeah, my question, it's a quick one. You said if we wanted to refer, to these materials later, where are these materials going to be located? I'm assuming they're somewhere.
I will. I'm going to email them, and
okay.
Nakia, I know you had said you were going to email them, but hold off on emailing them because if you send the PowerPoint, it'll break people's computers. I'm going to just turn this into a PDF, and I'll send it around.
Great.
After
Great.
the training, and I'm sure that they'll put it on the CHOP portal or something like that also.
Okay, great. Do I have to unraise my hand now, or do you do that?
I unraised your hand.
Thank you for unraising my hand.
I reached over and put it down.
Wow.
Yeah.
Technology.
Exactly, the power of the internet.
Thank you.
No problem. All right, so enrollment. And I love this again, thank you to Empire Justice, because I love how they made this with these big, bold numbers. It makes an incredibly complicated process that has so many opportunities to go off the rails. It makes it look so simple. How could this possibly go wrong? So there are just 4 steps. The first step is get assessed by the Conflict-Free Evaluation and Enrollment Center, which the Department of Health refers to as CFEEC. But I kind of like what some of the advocates call it, which is CFEEC, a phonetic pronunciation of that delightful acronym. And then step 2, you have to decide what plan you want to to enroll in. So you have to first figure out what kind of plan. We've been just talking about one kind of plan, but we'll talk about the other ones in a minute. And then once you figured out what kind of plan, you have to decide which specific plan are you going to call up to have them assess you. Step 3, you get assessed by that plan and decide whether you like them or not. And you can get assessed by multiple plans. And then step 4, actually enroll in the plan. That's something that you do with the plan. You sign an enrollment form that the plan gives you, and then the plan takes it from there. They submit that form and certain other paperwork to the New York State enrollment broker, New York Medicaid Choice, and they submit something to the Department of Social Services. And if all of the stars are perfectly aligned, then on the 1st of the next month, you would find yourself in that MLTC plan. So let's start with the beginning, CFEEC. This is also Maximus. This is the same company that does New York Medicaid Choice, which is the enrollment broker for all the Medicaid managed care plans. They're also the conflict-free center. And the idea here, what does this thing do? It wasn't always like this. Okay, it used to be that the plans, you would just call a plan was the first step. And the plans would be making an eligibility determination about, are you eligible to enroll in MLTC? Because as we saw earlier, not everyone is, right? If you don't need long-term care, you can't enroll. If you only need housekeeping, you can't enroll. If you only need social adult daycare, you can't enroll. Why is it that the state, with mainstream, that's not an issue? Anybody, you can be completely healthy and you can enroll in a mainstream Medicaid plan. This is different. The difference is that the state is paying something like $4,000 a month per member for everyone who's in an MLTC plan, because they're by definition, they have chronic conditions that they need almost, definitely weekly, almost daily help from their own home attendant, a single person coming and just helping them. It's very expensive. And so the state doesn't want to be paying a massive capitation to a plan that's got someone that doesn't actually need that much help, that's not that sick. So there's a clinical eligibility criterion for this. And it used to be that the plans were making that determination. Well, surprise, surprise, the plans were deciding that a whole lot of people were eligible who really weren't that sick, right? They loved the healthy people. So the state, and on the converse, they also were turning away the sick people. If you had someone who really needed a lot of home care, none of the plans wanted to enroll them. And so they were really getting shut out. And so to address those two issues, the state said, actually the federal government made them say, you have to have a conflict-free assessment step. You have to have an independent entity that's not one of the plans deciding whether somebody is eligible for MLTC. And once they get that approval, any plan has to take them. They can't be turned down. And if the conflict-free center says no, then no plan can enroll them. All right? So we've had that for a few years now, and there's good things and bad things about it. The good thing is that if you have high needs, if you need like 24-hour home care, once you get that blessing from the conflict-free center, the plans can't turn you down. They can't refuse to enroll you. They might disagree with the conflict-free center, and then there's a process for them to have their dispute aired, but that doesn't happen very often. And it's very rare that someone is denied by the conflict-free center. They have something like a 97% approval rate. So how do they decide whether you're eligible? You call them up. They schedule a home visit. The nurse comes. Now lately there's been some delays here, and you should let us know if you're seeing this, but they should be scheduling it within about a week. And we've seen some cases where it's more like 3 weeks before they actually have the home visit. So let us know if you're seeing that, and we'd really like to, I think they've taken some steps to try to address that. They've hired a lot more nurses there. So they come out and they come to the home, and the nurse sort of checks out the applicant and asks them a lot of questions, and you should certainly make sure that a family member or informal caregiver is present for that so they can provide information as well. It probably takes about 3 hours. It's pretty lengthy. And then they're going to tell you right at the end of that, yes or no. And if the answer is yes, then they say, all right, we can call Maximus right now. We can call New York Medicaid Choice, and they can educate you about your plan options if you want to talk to them about choosing an MLTC plan now. You don't have to wait until you're approved for Medicaid to do this. If this is someone who's new to Medicaid, you can actually have the CFEEC assessment before your Medicaid has even been approved. So that's one way to save a little bit of time in this process. Oh, Michelle, I just now saw your question about adult day health care. I assume that I answered that already, right? It was about whether MLTC covers only the medical model adult day care, or do they also cover the social model? And the answer is they do also cover the social model. Oh yeah, you said that you saw the answer. I'm sorry. Once you've been approved by the CFEEC, then that's like your hall pass, and now you can shop for MLTC plans. Now the MLTC plan is not going to want to assess you until your Medicaid's been approved, so that's something that when you're timing it out, I would say you should expect about 45 days turnaround on a Medicaid application. So maybe after 30 days, call the CFEEC to schedule a home visit. Try to get the CFEEC assessment in the last two weeks of your Medicaid waiting period, while you're waiting for a decision, and then ideally you get your Medicaid approval right around the same time that you get the CFEEC approval, and so now you can go straight to a plan, get that home visit scheduled, so that you can cut out as much delay as possible. Because this whole process, by the way, these 4 steps probably will take like 3 months. Right, like it theoretically is possible in 2 months, but I've never seen that happen. So you should expect it to take 3 months from beginning to end. So it's a long time for someone to wait. So anything you can do to try to squeeze that process is better. All right, so step 2, you've been approved. Now you have to pick a plan. Well, there's 2 different. The first choice is, do I want my Medicaid to be separate from my Medicare, or do I want them to be joined together? So the type of plan we were talking about in the beginning is the kind that most people have, the Medicaid MLTC, or partial cap plan, where your Medicare is left completely alone. If you have original Medicare, you keep that. And you have your Part D plan, which is separate. And you have a Medicaid card, which you can use to wrap around your original Medicare benefits. And then you also have an MLTC card, which you use for your home care and those other services like podiatry, audiology, and dental. But you could also choose to make your life a little more simple and have one card for everything, everything. So this would be a fully capitated plan like PACE, MAP, or FIDA. Those are the 3 types of fully capitated plans. So that means you would no longer have original Medicare. Or if you were in a Medicare Advantage plan before, you would no longer have that. This new plan would be your Medicare Advantage. It would be your Part D, and it's also your MLTC, and all of your Medicaid benefits would be all combined together into one managed care plan. All right, and these are the 3 different species of that: PACE, Medicaid Advantage Plus, and FIDA. So it's really a personal choice. There are some potential benefits of having everything combined under one roof. It can make your life a lot simpler instead of having like 4 different kinds of health insurance covering different things, or sometimes covering the same thing. You get, in most cases, you get some care coordination. So you would have a care manager or a care team at that plan who would help coordinate among all of your different providers, doctors, specialists, hospital, home care, etc. Whereas if you have original Medicare and straight Medicaid and MLTC, there really isn't that much coordination. The left hand doesn't know what the right hand is doing. The downside is it means basically you're enrolling in a Medicare Advantage plan, right? It means that you now have to make sure that all of your doctors and other providers are in the network of the plan. If you're enrolled in a PACE and your cardiologist only takes original Medicare, you can't go to your cardiologist anymore, right? Just End of story. Or if you go to them, you have to pay full price. It's not going to be covered by your insurance. So the PACE, MAP, and FIDA really make the most sense for someone who understands that, who's comfortable with working within a network, and that's something where we can help figuring out, well, what insurance plans do your doctors take? Maybe they are in the network of these plans, or maybe if they're not, maybe they can join. You know, sometimes the doctor is happy to join the network of like a FIDA plan, and we can help kind of reach out to the plan to see, you know, have someone from the plan contact them about joining the network. But for someone who doesn't want to have that limitation, they're going to prefer the Medicaid MLTC. It's the least amount of change in their health care. It means they're just getting a plan that covers long-term care and leaving everything else alone. So this is some more about the Medicaid MLTC. Again, like any Medicare covered services are not part of that package. And this is some more about MAP and PACE and some of the additional eligibility requirements. So step 3, once you've figured out what kind of plan you want, you now have to pick one of the plans. Depending on what county you live in, there could be between 2 choices of plan and 24. So there's a lot of variation there. If, let's say you're looking at one of the Medicaid MLTCs, you'll want to make sure that if you have preferred providers in that benefit package, that they accept that plan. So for example, if I have a dentist who takes Medicaid, I'll want to make sure that the dentist works with the MLTC plan that I'm thinking about joining. But I don't have to worry about whether my hospital is in network if it's a Medicaid MLTC, because my hospital is covered by Medicare and straight Medicaid. It's not part of the benefit package. If I'm thinking of enrolling in a PACE or a Medicaid Advantage Plus, then I definitely need to check to see if my preferred hospital is in network. If I'm in an upstate county where there's only one hospital within 100 miles of my house, it would probably be a bad idea to enroll in a PACE that doesn't contract with that hospital. So that's definitely something to check out. Once you've decided on a plan that you think is a good first choice, you call them and they schedule an assessment, and look, they've got 30 days to schedule that. So again, in terms of the delays, you want to pick up the phone as soon as possible. You can get assessed by multiple plans. You can either wait until after your first assessment if you're not happy with it to schedule a second one, or you can schedule them at the same time. I mean, not like you don't want the nurses coming at literally the same time to your home. That would be awkward. But you can, on the same day, place calls to multiple plans and schedule the assessments for, Tuesday and Wednesday, for example. You have the right to get a care plan in writing after that assessment. So this is different than the conflict-free assessment. The conflict-free assessment was not to decide what services you would get or how many hours you would get. It was just to decide, are you eligible? It's a yes or no question, okay? The plan decides what services they would give you and decides how many hours of home care they would give you. So that's why there needs to be a second assessment. And some people find this very frustrating, that I already had a nurse come out to my house and spend 3 hours asking me nosy questions. Why do I have to have this done again? And that's the reason why. So you can advise people, yeah, this is normal. This is how the process is supposed to work. What is uncommon is for the plan to actually give you something in writing saying this is how many hours we're going to give you if you enroll with us. That's a really important piece of information. This is a plan that the only reason you're enrolling in it is to get home care. It's not about your doctors or hospitals or drugs. So it's pretty important for you to know how many hours they're going to give you, because if a plan decides they're going to give you fewer hours than you think you need, you wouldn't enroll with them. You'd keep shopping around and find a different plan and see if they give you more hours. So we should remind consumers to insist on getting a written care plan. Most plans won't do this, so it requires a little bit of advocacy, but they are expected to provide that. So finally, light at the end of the tunnel. You've picked what kind of plan you want, and you've picked which, you've gotten assessed by the plan, and they've given you a written care plan, and now you can actually go through with the enrollment. So if you're in one of the Medicaid MLT, if you've chosen one of the Medicaid MLTCs, then you enroll through the plan, okay? You get an enrollment form from them, and like I said, they take it from there. They should be, submitting the enrollment to New York Medicaid Choice and to the LDSS. And none of your other health insurance should change. You're going to keep exactly the same Medicare that you had, same Part D plan or same Medicare Advantage plan. If you had a Medigap policy, you'll keep your Medigap. It doesn't affect that at all. And the only change, I think about it like they're taking your Medicaid card and they're cutting a corner off of it, right? There's a subset of your Medicaid benefits that are being carved out of your Medicaid card and put on a separate card with that MLTC plan. That's the only change. If you've decided to enroll in a combined plan, a MAP or a PACE, again, you still have to enroll through the plan, but one consequence of that is you will automatically be booted from your Medicare Advantage plan, if you had that, from your Part D plan, if you had that, or from your mainstream Medicaid plan. This might be someone who had Medicaid first. If they had Medicaid first before they got Medicare, then they were probably in a mainstream plan, and then they maybe aged into Medicare when they turned 65, or they were on disability benefits for 2 years. So for that person, they already had a mainstream plan, and when they start getting Medicare benefits, they're going to get kicked out of that mainstream plan. And for those of you downstate, in FIDA, you actually can't enroll with the plan. You have to go to New York Medicaid Choice. You call them. They have separate phone numbers for all these different functions, by the way. So make sure you're calling the right one. But if you call their FIDA number, they can enroll you in a FIDA plan. The timing is really critical with these enrollments. So you have to get the enrollment processed by noon on the 20th of the month in order for it to be effective the 1st of the next month. This 20th of the month rule causes a lot of problems for people. So if you've timely contacted the plan, if you have had that assessment by the plan early in the month, and you said, yes, I want to enroll, and you signed the enrollment agreement in the first week of the month, I would really expect them to get that put through by the 20th. And if they don't get it put through by the 20th, that's their fault. So let us know if you hear of cases where the plan's delay leads to someone missing the 20th of the month. Because that means they've got to wait a whole extra month before that enrollment takes effect. All these enrollments are the first of the month. You can't enroll in the middle of the month. Some good news about this, which unlike mainstream plans, there's no lock-in. All right. So with mainstream, you have a certain period where you can switch plans, and then you get locked in for a year before you can switch again. That's not true for MLTC. For any of these kinds of MLTC, whether we're talking about the Medicaid MLTC, MAP, PACE, FIDA, you can switch plans anytime you want, and it takes effect the 1st of the next month. There are certain rights that you have in MLTC, similar to the rights that people have under mainstream Medicaid managed care. This slide here talks about the transition of people who newly become eligible for Medicare, right? So this is someone who had a mainstream plan, and then they age into Medicare, or they disable into Medicare. This policy, which there's a link to here, explains how that's supposed to happen. It should be a seamless transition. If somebody's getting home care services in their mainstream plan, and now they need to switch to MLTC because they've become eligible for Medicare, they shouldn't lose their home care services. They shouldn't be reapplying for an MLTC plan. It should be a seamless process where their services just continue. For someone who is in a newly mandatory county, and there probably aren't that many of these folks left, but for certain upstate counties that just in the last couple months went mandatory, there may still be folks who are transitioning from fee-for-service. So this slide only applies to those people who are transitioning from fee-for-service home care services into MLTC because their county just went mandatory. Everybody downstate can ignore this slide. It doesn't apply to anyone anymore because you've already transitioned if you were receiving services, and if you haven't transitioned, then you're new to care. You're a new applicant, and these things don't apply to you. But if you are in a newly mandatory county, and let's say you were getting personal care services through the local district, and now you've been sent a letter saying you've got 60 days to pick an MLTC, or we're going to pick one for you, when that happens, when that enrollment happens, you get a 90-day transition period where they have to continue the same services and the same provider for the first 90 days after enrollment. And then at the end of that 90 days, if they want to change anything, they have to give you timely, adequate notice with appeal rights. If you're new to care, if you're, let's say, in New York City or Westchester County, and you're newly applying for Medicaid and then enrolling in an MLTC, you don't get any of this. It's caveat emptor. You get assessed by the plan, they tell you how many hours they're going to give you, and you're a consumer. You're making a choice of whether you want to enroll in that product or not. And if you don't like the deal that they're pitching, you can take your business elsewhere. Once you enroll, you might have the right to appeal. Like, let's say the plan says, okay, we'll give you 12 hours a week. And you say, okay, and you sign up, and you get enrolled, and you're getting 12 hours a week, and then you wake up one morning and say, this isn't enough, I need 20 hours a week. In theory, you might be able to appeal that. Or you can always request for more hours. You're not locked into that. You can say, well, my condition changed, I think I need more hours. And the plan is required to at least process that request. And you would have appeal rights if they say no. This slide talks a little bit more about some of the rights you have in MLTC. You have the right to aid continuing if your plan wants to change the services that they previously authorized. You get the services to stay at the same level while you're having a fair hearing about that. Now this slide talks about, this section talks about some special Medicaid budgeting issues. So you'll notice that for the rest of this presentation, I haven't said anything about income or resources or household size or residency, and that's because once you're eligible for Medicaid, you're eligible to enroll in MLTC. You just need to have community Medicaid, and that's the only financial requirement for MLTC. You can be an MLTC even if you have a spend down, right? Unlike mainstream, that's not an obstacle. There are lots of people in MLTC who have a spend down, and the way that it works is you pay your spend down to the MLTC plan. This is also a common enrollment problem, that someone will be approved for Medicaid with a spend down. They didn't submit any medical bills. The way that they're going to meet their spend down is by being enrolled in an MLTC plan and getting billed for the spend down. So that person then contacts the plan for enrollment, and the plan says, oh, we can't assess you because you don't have active Medicaid. And the person says, what are you talking about? I have a Medicaid acceptance letter right here. It says I'm approved for Medicaid. And they say, well, we can't see you in e-paces, so we can't send a nurse out. That's nonsense. That's not what should be happening. They have to convert your Medicaid case in order for them to process the enrollment. And this is what often happens. If you're approved for Medicaid with a spend down, you have this kind of phantom Medicaid because they haven't put your coverage up yet because you haven't met your spend down. So it looks like you don't have Medicaid. But there is guidance about this, and it's very confusing. But suffice it to say, that's not the answer people should be getting. And if someone tells them, oh, you need to pay in your spend down before we can enroll you, that's also not true. Okay, and if they do it, it'll probably screw things up even more. It's enough to just have been approved for Medicaid with a spend down. That's all you need to do to enroll into the MLTC plan, and then the plan will start billing you, for your spend down amount from your first month of enrollment onward. There's special budgeting rules for people in MLTC. Most, again, 99% of this, from Medicaid standpoint, is the same as everything else for non-Magi Medicaid people. But there are a couple of special rules. and these are just important to flag, because if you catch these while you're working on cases, you can really help somebody. They're not well known, and the plan is not going to tell people about them. The local district is not going to tell people about them. It's us or nobody. So the spousal impoverishment budgeting that someone would get if their spouse was in a nursing home, you now get for a spouse getting MLTC in the community. So you've got a married couple, one of them's on Medicaid with MLTC and one of them is not. The upshot is they're probably going to get to keep all of the income and resources and not have a spend down at all. And even if their collective resources, if their assets are over the Medicaid limit, they're probably going to get to keep the resources without doing a spousal refusal. If their resources are under like $79,000, they're probably going to be able to keep, I'm sorry, $75,000. They're probably going to be able to keep all of their resources and keep all of their income and not have a spend down. So it's a huge improvement over what the budgeting used to be, which was just, well, you're a married couple, spousal deeming applies, all of the non-Medicaid spouses' income and resources are deemed to the applicant spouse, so you're either going to be ineligible or you're going to have a high spend down, and you probably have to do a spousal refusal. You might not need to do a spousal refusal with this spousal impoverishment budgeting. This you get after you've been approved for Medicaid and after you enroll in an MLTC. You can't get this on the front end. So it's a little strange. You might actually have a case where you do a spousal refusal for someone, get them on Medicaid, get them enrolled in an MLTC, and then you ask them to rebudget with spousal impoverishment rules, and you basically tear up the spousal refusal and say, now I don't need it anymore, treat us as a married couple, and use the spousal impoverishment budgeting. Another thing to just keep an eye out for, if someone was in a nursing home for more than 30 days, or an adult home for more than 30 days, and Medicaid paid for it, and now they want to come home and get MLTC, then they will get a special income standard that will allow them to keep a lot more of their income. It will be another deduction from income in calculating their spend down for housing expenses, for rent. So it comes out to, I'm not sure what the amount, it varies by region, but in New York City it comes out to something like $1,000 a month. So most of your clients, probably their spend down is less than that, and it would just wipe out the spend down. So just keep an eye out for those people who are trying to transition from a facility back to the community going into MLTC. That's when you get the benefit of this special budget. Susan, you had a question.
Yeah, I'm curious about this in terms of, for people who aren't aware of it and sort of who are not represented, whether this happens or whether it's overlooked, and if it does happen, like who's the one who, or I don't know, how is that? How does it come to be without an advocate?
It does not. That's the very sad answer. I don't know that there is any sort of duty to notify or duty to screen on the part of a nursing home or an MLTC plan with regard to this shelter allowance. For spousal impoverishment budgeting, there was a Medicaid update that I think it's the local district or the plan actually is supposed to be screening people for that.
Explain that. What is disregarded?
So it's a flat. I'm going to try to remember how it works. It's a flat, I'm not sure if it's up to, I guess it's you basically would get a deduction from income of a fixed amount that varies by region
Okay.
for your shelter costs. So, this is something that I've thought for years would be something so helpful to have in New York State Medicaid, a shelter allowance like they have for food stamps.
Mm-hmm.
When people's shelter costs vary so much around the state, it's
Right.
it's crazy that someone with a rent of $300 a month has the same Medicaid income standard as someone whose rent is $1,000 a month. They might be equally poor. That you might have someone whose income is much higher, but is equally poor as someone with much lower income because they have a lower rent. But they don't. Medicaid doesn't care. Medicaid doesn't care about how much your rent is, right?
Right.
This is the only time when they do. Is if you're coming out of a nursing home and getting so yeah, it just means that you would get this fixed amount subtracted from your countable income, which in most cases would wipe out your spend down.
But it's also interesting. Oh, so it's an income disregard just for the purpose of the spend down. Okay, got it.
Yeah, I mean, because you're eligible under non-magi rules. There's no such thing as having excess income. Basically, I mean, you would just have a really high spend down, but there's no amount of income at which they would say, well, you're just ineligible for Medicaid. So it's always about how much your spend down is. One thing I didn't mention that I should have is that if you're in an MLTC plan and you have a spend down and you don't pay your spend down, the plan can disenroll you. That doesn't mean they will, but they have the right to. They have to try to get you to pay. They have to, if you want to make arrangements to pay, which is sort of a vague term in the contract, then they can't disenroll you if you're trying to make arrangements to pay. And I would interpret that to mean, for example, enrolling in a pooled trust. But if you just aren't doing a pooled trust, you don't qualify for spousal impoverishment, you don't qualify for the shelter disregard, you have a $400 a month spend down and you're just not paying it probably because you can't afford to. Eventually, the plans, you're probably going to owe the plan a few $1,000s, and eventually they're going to say, well, we don't like this, you owe us a lot of money, and they can disenroll you. They have to go through a process, and it has to be approved by New York Medicaid Choice, which doesn't always happen. So you should have notice and fair hearing rights and aid continuing rights if that should come to pass. But at the end of the day, they can disenroll you. And then you would have to try to find another plan that you can enroll in, because you can't get home care services fee-for-service anymore. Because MLTC would be mandatory. So I haven't seen a huge problem with this of someone who's sort of like a hot potato that gets booted from plan to plan to plan. But that's something that we're watching. Interestingly, FIDA cannot disenroll you for non-payment of your spend down. So for someone who's downstate, that's sort of a little loophole, extra perk of FIDA. If you enroll in a FIDA plan, and you can't afford to pay your spend down, they just sort of have to eat it, which is not something that I'm sure is not something that they're thrilled about. But one idea that I think some plans do is they say, well, we're the ones who will benefit from this person enrolling in a pooled trust, because it means that we won't get shorted on the spend down every month. And so some plans actually help people enroll in pooled trusts, which I think is a good thing if they do it, properly. All right, so I am actually, and not surprisingly, out of time, and we have, just gotten to our section on FIDA, but I think this is probably just as well because a lot of you on the call are outside of the FIDA region and are just going to, tune me out if I drone on about FIDA for a long time. But suffice it to say, FIDA is a demonstration program in New York City and Nassau County. So for anybody outside of New York City and Nassau County, you can't enroll in FIDA and you don't have to think about it. It will be starting in Suffolk and Westchester sometime this coming year in 2016. We don't know exactly when. And it's one of these fully capitated plans. But I guess the short version of it is it's really like a supercharged MLTC plan. If you had to be in some form of MLTC, this would be the plan to join, I think. It's got a lot of very consumer-friendly features. There was a lot of stakeholder engagement with advocates in the development of FIDA over the last few years. And so there are a lot of good things about this design. There are some challenges about it as well. I think the biggest one for most people is just it means that you're not in original Medicare anymore, right? It means that you're basically in a Medicare Advantage plan for your Medicare benefits. And if you have doctors that don't want to do anything with managed care, if your doctor doesn't participate in the FIDA plan, then you'd have to change your doctor. So for a lot of people, that's a deal breaker, understandably. And a lot of what we've been doing in ICAN in our first year has been advising people about FIDA and helping them figure out whether their doctors will accept a particular FIDA plan, helping them figure out if their drugs are covered, and trying to educate providers to an extent about what would it mean to participate in FIDA. But at the end of the day, if somebody says, look, I'm not interested, they don't have to do it. It's not mandatory. It's not like MLTC. FIDA is a voluntary program. They did something called passive enrollment, which is now actually over in the first year. Passive enrollment meant that you would get a letter saying, in 60 days, we're going to put you in the same FIDA plan as your MLTC. So this is going out to people who already have MLTC, and let's say you're in GuildNet MLTC, the letter would say, in 60 days we're putting you in GuildNet FIDA unless you tell us otherwise. Well, a lot of people called to opt out and said, no, I want to keep things the way they are, thank you very much. And so they would stay status quo, they wouldn't go in FIDA. But if you didn't make that call, if you didn't opt out, you would be passively enrolled into your MLTC plan's FIDA product most of the time. There were some people whose plans didn't have a FIDA, in which case they might get passively enrolled in a different plan. But for people who were passively enrolled or people who opted in, if they changed their mind about it, they can always disenroll and go back to what they had before. So right now, what we're really looking at is this is a voluntary program. There are a lot of potentially good things about it, but it's not for everyone. And we've been really trying to help people identify whether FIDA is right for them and what some of the benefits might be. It has a gigantic benefit package. I mean, it covers even waiver services. So the same services you could get through NHTD or TBI waiver, you can get through FIDA. It covers things like doctors who make house calls. It covers transportation, not just to doctor's appointments, but potentially transportation to go to church on Sunday or something like that. So here's sort of a very basic pros and cons of FIDA, and just something to think about. There's been, I think, a lot of misinformation about it. A lot of providers are uncomfortable with it because it creates sort of additional obligations for them in terms of this interdisciplinary care team. But from the beneficiary's perspective, there's a lot of potential benefits. So we're trying to keep an open mind about it and help identify people who would be a good fit. And you can feel free, once we email, well, I guess the slides were already emailed, feel free to browse through this if you have cases involving FIDA, and of course feel free to just send them our way. ICAN is sort of a creature of FIDA. That was like part of why we were created, is to help advise people about this new duals demo. So by all means, you can refer people to us, and we will go through their options with them. All right, well, thank you so much, guys. If you have any questions, I can answer them now.
Hi, David. It's Alex.
Hi, Alex.
Hi. Thanks for the presentation. I was wondering if you could just touch on what issues people might see if they have a client who is not dual eligible and is enrolled in Medicaid through the marketplace, and they might kind of think that MLTC is an option or be told by someone that MLTC is a good idea, and what people should look out for.
Great question. Yeah. So as Alex has been dealing with a lot, these transitions, one of the confusing things about MLTC is that if your Medicaid is through New York State of Health, you can't enroll in an MLTC plan. You can't enroll in any of them. The MAP, the PACE, the FIDA, MLTC, it just won't stick. It's just a computer thing. And so if you legitimately need to enroll in MLTC and you currently have Medicaid through the marketplace, your Medicaid case has to be transferred from the marketplace to the local DSS before that enrollment can happen. So that's a potential sticking point. But there's a threshold question of, if you have Medicaid through the marketplace, do you even need to be in MLTC? There are some good reasons and some less good reasons to want to switch into MLTC if you have marketplace Medicaid. One good reason is you just became eligible for Medicare, right? If that's the reason why you're getting booted out of your mainstream plan and you need home care services, then you have to leave the marketplace. I mean, you have to leave your mainstream plan, and in order to get, if you're leaving your mainstream plan and you need home care services, you have to get them through an MLTC. You won't be able to get them otherwise. So, ipso facto, you have to get off the marketplace and you have to get to the local district. So that transition is one that, we would expect to see when you have, for example, someone with disabilities who's receiving home care but has not yet reached their 2-year anniversary of SSD so that they qualify for Medicare, or someone who is just turning 65 and maybe isn't even receiving disability benefits, but they're getting home care. So those folks will definitely have to go through that transition. But let's say you have someone who isn't about to get Medicare, and they just get home care. If they need to get home care, they just get it through their mainstream plan, right? They don't need to change into an MLTC plan. They would just call the member services number at their mainstream plan and say, I want to apply for personal care services. How do I do it? And the answer is going to be they need to get a physician's request form. In New York City, that would be the M11Q. Get it filled out by the doctor, signed by the doctor, and then they need to send it to their plan. And there's a prior approval process. The plan needs to send a nurse out to the home to do the assessment. And if the person is found eligible for personal care services, then the plan will assign a home care agency and authorize them to provide however many hours per week of services. And that's really how it should work. You don't need to switch to MLTC to do that. Now there's that small number of people who might need, let's say, social adult daycare, or they might need environmental modifications, like they need to have grab bars installed in their bathroom. Those are services. There's really just 3 services that are in the benefit package of MLTC that you can't get through mainstream. And they call it social and environmental supports, which is a very vague term in the model contract. And the only thing that we know for sure that includes is environmental modifications. The second one is social adult daycare. And the third one is home delivered meals. So if you have a demonstrated need for one of those 3 things, then you should be able to switch to voluntarily enroll in MLTC, even though you're in a mainstream plan. And so there's a couple hurdles you have to get over. The first one is you have to convince somebody that you actually need one of those 3 things. So you're going to need a doctor's letter. And the second thing is you're going to have your Medicaid case transferred from the marketplace to the local district. So if you identify people who are in that bucket, by all means, send them to Alex. I don't want them. Just kidding, Alex. And you know, she can try to help you figure it out because it's a little bit messy, to be honest. Susan had asked, relatedly, you know, what is the benefit of voluntarily joining MLTC? You know, it's mostly hypothetical. I think that some people think that they will get more hours if they're in MLTC as opposed to a mainstream plan. Remember, the mainstream plan is getting a lot smaller of a capitation each month. The MLTC might be getting $4,000 a month, and the mainstream plan might be getting like $400 a month. So it creates a financial incentive to give, you know, fewer hours, certainly. But they are on the hook to provide just as many hours as are medically necessary for you, and they can't define the scope of services they cover any more narrowly than fee-for-service Medicaid. That's true for all kinds of Medicaid managed care in New York State. So whether you're in a mainstream plan or an MLTC, they can never say, oh, you need too many hours. We can't pay for that many hours. You know, oh, if you need that many hours, you need to be in a nursing home. Or if you need that many hours, you have to be in an MLTC plan, not in a mainstream plan. Those are all the wrong message. They can't tell you that, okay? So if you're in a mainstream plan and you need 24-hour care, guess what? They have to pay for it. And I would say, just from a strategy perspective, as much as it might seem hard to get a mainstream plan to give 24-hour care, it might actually be easier than trying to get that person switched into MLTC. So you might want to just stay put and fight rather than trying to get them switched over. Are there any other questions? Oh, Patricia, you had a question about, is there a list of what Medicaid covers for dual eligibles? So the answer is, if you have New York State Medicaid, the list of services that are covered is the same for everybody in the state. It doesn't matter how you got Medicaid. It doesn't matter what category you're in. And it doesn't matter what kind of plan you're in. The list of services that you're eligible to get coverage of is uniform statewide, because that's what's in the New York State plan, the New York State Medicaid plan, which is the contract between the state and federal government about how we're running our Medicaid program. The only exception to that is there are waivers. So in the waiver, if you're in a waiver program, you might get extra stuff that most Medicaid recipients can't get. And that's also true for like FIDA, that you could get some extra stuff that other Medicaid recipients don't get. But 99% of the time, Medicaid is Medicaid, and the list of covered services is the same. So if you're dual eligible and you've got Medicare, Medicaid has to cover all the same stuff for you that it would cover for someone who doesn't have Medicare. Medicare is going to be primary, but anything that you need that's covered by Medicaid, Medicaid would have to pay for. Now, if the question is what are the list of services that are covered by an MLTC plan, that's a much shorter list. And I did give you sort of an abridged list on that other slide. If you want to see the complete list, I would refer you to the model contract. That's kind of the Bible for MLTC. It's the contract between the plan and the state. And I believe it's Appendix K1 or something. It's one of the appendices at the end, probably around page 200 and something. It's kind of a long document. That appendix has a list of all of the services that are covered under a partial cap MLTC. Any other questions? No? All right, well, thanks everyone. Nakia, Alex?
Yes, yes, thanks David. Thank you so much for that training. Very informative. So I guess that wraps up our monthly meeting. I just want to wish everyone a happy Turkey Day, Thanksgiving, and yeah, happy holidays. Bye.